CT scans of the 4D and tried to robustly optimize it. And he showed a star. Target dose coverage is always robustly optimized. That means that dose coverage is guaranteed up to the robustness that's achievable for the target. Then sometimes you cannot really robustly optimize for all the OARs because it becomes too difficult to meet all kinds of things. So you robustly optimize the dose distribution for selected organs at risk. He chose brainstem to optimize it. Brainstem, optical chiasm, and also probably pituitary or something like that. He chose that because they are very close to the target, so that's why they are robustly optimized. What do you mean by robustly optimized? The plan is optimized such that the plan remains, the target coverage remains very robust, or in the sense the target is covered under those. If you have 3 to 4, up to 3.5% range uncertainties in your CT scan, okay, either the beam can move 3.5% forward or deeper, or 3.5% proximal. So in both scenario, the dose coverage target is guaranteed if you do robust optimization, okay. And then the 4D CT means the dose distribution remains robust within the breathing pattern, okay. One extreme is 0%, one extreme is 50%, and then the average phase. That's we see the dose will remain same. So of course the robust optimization is done. The optimization is done to meet the criteria. Then eventually you have to evaluate the robustness. That's called a robust evaluation. So after robust optimization, he clicked robust evaluation, then created some scenario where he wants to look at it. Once you do robust evaluation, then the dose distribution in different scenarios will be displayed. So you can look at it. You can look at something called a band DVH. In the band DVH means it is okay. What is a DVH? It's called a dose volume histogram. DVH stands for dose volume histogram. How much volume is getting how much dose? That is what is being plotted. So this is a good way of looking at comparing plans. So if you have 12 scenarios of uncertainties, then the DVH for a particular organ will be displayed for that 12 scenario, creating a band. So if the plan is very robust, what you expect in the band? The bandwidth will be very small. If the bandwidth is too large, then the plan is not robust. Then the DVH is changing with the different scenario. So objective of robust optimization is to have that bandwidth of that DVH as small as possible. Okay. The area of research in this robustness and all kinds of things ongoing. One of the important thing to look at it, how does this robustness affect the clinical outcome? Are we just afraid of it, or is it really getting the clinical outcome better? Okay, when you do robust optimization, what happens? You are trying to, if you are doing a robust optimization for the target, you are trying to put the dose a little deeper and a little proximal. So in that way, the tissue in the distal part is getting more than what you would have done if you know robust optimization. Robust optimization is blurring or over covering, so that way the plan target will remain covered on those scenarios. But you are also irradiating a lot of normal tissue. No, there is no free lunch. You have to give up something in order to get something. So it may so happen that this 3.5% may not be true. It may be only 1%. So in that case, you are doing a lot of dose giving to the normal tissue. Maybe it is 5%, then you are not giving the target coverage. So eventually, when you gather this kind of data, that you can develop some of the DVH matrices and look at is there any correlation with the actual treatment outcome. So eventually, that evaluation will tell you that whether this robust optimization is satisfactory or overdone or underdone. Okay, so you create a stock portfolio. Okay, you create a stock portfolio. You look at it, how the different companies are performing. So you wanted to hedge it. You hedge it in the sense that you wanted to buy some high risk stocks, some low risk stocks. Eventually, you want to end up with a certain level of return. Okay, you hedge those risks in different stocks and expect that, okay, I can get a 10% return. But in actuality, whether that risk that you have evaluated is true or not, how will you know? Because after 1 year, you look at what is your return. If it is more than 10%, then you think that, okay, I was too careful, but anyway, it worked. If it is less than 10%, your risk, you probably properly didn't evaluate it. That is the thing. This is a risk stratification. You evaluate, that's the job of the physicist, that's the job of the physicians, to just not do it and then also evaluate it. With a number of patients being gradually more and more patients are treated with robustly optimized plans, you have more data to analyze. So data analysis is a very important thing in evaluating the clinical outcome. Okay, there is a lot of room for doing a lot of research on this kind of thing. So then what he showed us, he went to show arc planning. As I have mentioned something about the arc. In the arc planning, what happened is, instead of beams going only from 2 or 3 directions, you have a large number of directions from which beam can come in. So he showed 20 directions in which he is sending the plan. In actual arc, the arcs can be, the gantry can be rotating around about 360 degrees. But that capability is in the dynamic arc, that is not available yet in protons. It is available in photons, X-rays. That's called volumetric modulated arc therapy. We wanted to do same thing like that in protons, but the system is not ready. So if you have 20 different beams, you have more degrees of freedom to optimize, and specifically the LET optimization. Okay. So that he showed that how the VMAT plan gives a better LET distribution for the critical organs. Okay. Even if you do LET optimization with static beams, that is not also as good as the arc plan. So arc plan works better. So in order to have a desirable LET distribution, the arc therapy will contribute, will be very useful. Okay. Then he went to adaptive planning. I have talked about adaptive planning. What is adaptive planning? In adaptive planning, during the course of treatment, you take a patient's image, different images, 4D, either CT on rail images or similar, or CT on cone beam CT images. You look at it, what changes are happening. Then you calculate the dose in those new CT scans and see if the plan objectives are still met or not. If not met, then you create a new plan. So in order to reduce the time of doing that new plan, they have already done some automation. In that automation, you take the new CT and just click a button, and then it can generate a new plan. That's a great thing, because that's what we have done, because that adaptive planning is not available now in the current version of RayStation. So at our place, we have written some scripts to automate them, so that the time it takes to create a adaptive plan is reduced substantially. And it is necessary to do an adaptive plan as quickly as possible, because the patients are under treatment. The treatment cannot be interrupted, so it has to continue. So, but you don't want to use the old plan, because the old plan is no longer working, it's not good for that treatment. So you have to generate a new plan as soon as possible. That's why automation of adaptive planning is very important. So those are things he showed how it is done. Did you get a good idea what the planning, proton spot IMPT planning is about? Okay, I'll just summarize in a few sentences. Let me see if I can go back, because that is the most important thing. If you don't know, then whatever I show, it doesn't matter. Okay, you have to remember some good things that you learn here, something that will stay with you for long. I am going to come up with some sentences about planning. Okay, this is something very important that you should know. I didn't have time at that time. I am going to talk to you again. Okay, all right. I'll show you some examples. So today is mostly, rest of the time we have another 45 minutes. I'll give you some time, 15 minutes at the end. We'll talk only for half an hour. Another 15 minutes you talk, I listen. Okay, so that's what happened. Otherwise you are all going to falling asleep. Okay, I don't want to see you to sleeping here. Okay, so okay, so let's look at it in spot scanning beam planning. You will hear this term that's called SFO. I have already talked to you. In SFO, if you are using 5 fields for treatment, each field is the spots for each field are their weight, that is the intensity, and is optimized. Your question? No, they are optimized individually, and so that way, how the other beam is delivering the dose is not taken into account. You wanted to make sure that one particular beam is covering the target. Mostly SFO plan is done for target coverage, but you can also ask some kind of put some OR objectives, it will try to meet. But most important, the major objective for SFO planning is to make sure that beam is covering the target individually. So you have individual, just like in 3D planning, you have individual fields, and that individual fields are covering the dose, and the total dose is sum of each field dose. You have some opportunity to change the weight of each field. Okay, total weight is 100%. You can see that this beam is not a good beam. I will give you only 20% from that beam. I will give 30% from this. That only that you have that parameter to optimize in a single field optimization. But the individual spots, their intensity is optimized individually to meet the target coverage objective for that field. Okay, but inside when you are doing SFO, you do not have to get a uniform dose. You can decide different targets in the sub volumes, and you can ask them to cover with that dose. That is called simultaneously integrated boost. You can have some high regions, low regions, that individual field, the spots will be optimized to achieve that goal also. Okay, but it doesn't have to be uniform dose. If you want a uniform dose, that has a new name, that's called single field uniform dose. You can also look for it, or you can ask for single field integrated boost dose. Those things can be done, but the key point is in SFO, spots of a particular field are optimized only for that field. It's not taking account of what other fields are doing. Now you go to MFO, that is called also IMPT, full IMPT, intensity modulated proton therapy. All spots from all fields are optimized simultaneously. You have all the spots together. Your objective, what is optimization? At least I should ask you. I am talking about too much about optimization. The optimization is you have a target, you have some objectives to achieve. Okay, and then the plan has a certain parameters. That's in this case, what are the parameters? The spot intensity. The spot intensity is the only parameter that we have. That because we have already decided that what is the spot spacing and what is the spot direction and all kinds of things. If you don't have any, if you do a complete full arc therapy, the beam direction is doesn't matter. If all the spots are coming from all directions and all those total spots, their intensity will be optimized. The optimizer in IMPT is trying to decide what weight of all possible spots that are coming from all beams will have. So that is what you are optimizing to achieve your objective of covering the target with the prescribed dose and giving keeping the dose of the organs at risk below their tolerance. Okay, so that is the objective function. I have showed you that objective function. When you go robust optimization, in robust optimization, that objective is for all scenarios. That objective has to meet in all scenarios. So you see the dimension of optimization space becomes very large as you choose large number of uncertainty scenarios. Okay, he showed that how many scenarios he is optimizing. He had 4 CT scans and 2 range uncertainties, plus 3.5%, minus 3.5%. So 4 times 2 is 8. So he optimized that plan for 8 scenarios. If you add another 6 scenario of setup uncertainties, then it becomes 48. Okay, 48 scenarios. And you can also have an opportunity to move the beam independently, move around. Okay, because by the time you treat the patient, the isocenter, the patient may have moved the isocenter maybe at another location. So that's why that if you want to do real very big optimization, then you can also choose beams to be independently moving around. All those scenarios are there. You choose what you think is happening in actual treatment. Okay.
So,
Yeah.
that scenario that you mentioned, it is like the best of the 48 or best of the 12 scenarios he selected, or is there any reference to select which scenario to be selected?
No, it's your choice. You say that, okay, in a range of uncertainties, I only have a 3 plus minus. So it will always be only 2 scenarios. And depending upon how many city, in 4D city phases you are optimizing, you have the choice. You get 10 phases. You may not optimize in all 10 phases. You may optimize only in 3 phases. Then you have 3 scenarios. Plus each scenario have a 2 plus minus range. So it becomes 6. And then you have a set of uncertainties in x, y, z, x direction 2, y direction 2, y direction 2 and z direction 2. So you have 6. So 6 times whatever you had before 6 is 36 scenario. So that is depends on what you want to optimize. You have choices. You have to choose whether you are doing setup uncertainties, range uncertainties, and also 4D uncertainties. You can do independently. You don't have to combine all of them. But you can also you can do combined robust optimization also. Okay. So the scenarios are determined on what you want to do, what you expect that is to happen during the treatment. Okay. Though in intensity modulated proton therapy or multi-field optimization, the weight of each spot is optimized using an inverse planning process without dose constant to target volumes and critical structures. Okay, let's see what I had before. Let me see, give me 1 minute. How is my battery doing? I have enough. I can take this one. You know how to do this one? There's something else to be connected with? This is it?
Yeah, this is, I think it's perfect.
Yeah. Okay. So what happened is when you are optimizing each field individually, so the dose distribution becomes a little bit more robust because all the spots are the patching of those spots from other beams are not taken into account. So that's why you get a better robustness of the plan. But sometimes this SFO cannot be used for all targets. So for example, for prostates, this works very well because you only have 2 fields. There are not many critical organs, and each field is covering by 50% of the dose of your prescribed dose. That works very well. Okay. Some isolated brain lesions. Nothing is nearby. That's the kind of a dream site to make a plan. So also prostate. And so everybody wants to have a prostate plan to do and check. Everybody hates to check the brain plans. Okay, because of the so critical organs are so nearby, how to keep them under, keep them safe is a nightmare. Okay. And generally, this SFO is used for irregular shape target. Can avoid high dose to wear, easier to achieve planning goals, has very complex dose distribution within each field, large uncertainties than SFO. Okay. Okay, we have gone through this. Let's look at some examples. That's what I wanted to do. Let's look at some example. These are single field optimized dose. So what happened is there are 4 fields. Okay, this will tell you what SFUD is. Single field uniform dose plan. Okay, SFUD is every field is optimized individually. You see, this is our target. Where is the field 1? The field 1 is going from this direction and completely covering the target. Field 2 is coming from this direction, covering the target. Field 3 coming from this direction and is covering this target. Same thing also F4. You sum them up, you get a combined dose distribution. Not each individual field is homogeneous across the target volume, okay? That is the goal of a single field uniform dose, and that is done by single field optimization. In a treatment planning system, it gives you an option. You want to do single field optimization or you do multi field optimization, you check it. So that's done, okay? But you got the concept, okay? An example of a SFUD plan that we have already discussed. Let's move on. Okay. Take TV virtual 3D block. In order to carve out dose to neighboring critical structure, needed to able to block out structures. Modified a target volume used to define virtual 3D block. So what happened is, if you want to protect, give low dose to a nearby organ, then you modify your target accordingly. So you try to make sure that, okay, don't cover the whole target, only cover this target, okay? That's how you can control your dose to the dose given to the OAR nearby. Now this is the example of an IMPT plan. In the IMPT plan, you see this distribution field 1, look at it, how it looks. Look at field 2, how it looks. Field 3 and field 4, look, it's completely different. All these doses from individual field is different. But the plan was optimized to get this distribution. Then we are looking at individual dose, which are not supposed to be same, okay? Because we are not optimizing individual field to cover the target. Here our optimization objective is to cover this part, and then individual field doses doesn't really matter to us. But since this individual field dose distribution is not as homogeneous as you see the combined plan, so the effect of uncertainties in individual fields is pretty high. So that individual uncertainties, when you add up this plan, the effect of uncertainty is much higher in the combined dose, okay? If you have a uniform dose individual field, they are not very much affected by uncertainties, your combined dose distribution will not be affected. But if your individual field dose is affected severely by the uncertainties, your combined dose will be affected. So that's why we tell that if you have a simple target, you can always use a single field optimization or a single field uniform dose, get your objective, the uncertainties will be much less, okay? What is this? This is SFUD for a single 2 lateral fields. This is for prostate. Then you can see that the target dose is probably 70, 80, 100. That's covering very well here 2 lateral fields. Let me see why I am showing you. Oh yeah. So you see the right lateral field is also covering the target. Is the left lateral field. Is that left lateral field? Yeah. The left lateral field is also covering the target. So this is a single field uniform dose. Yes. Okay. This is IMPT field. The same plan is done with multi-field optimization, and let's see how the individual field looks like. You see, individual field, this part is not homogeneous anymore because those fields are optimized together. You go to that one is not homogeneous anymore, but the combined dose is uniform. This is not necessary to do IMPT for this MFO plan for this. We don't do it. We always do single field optimization for these simple targets. This is just an illustration purpose that how the dose distribution looks for a multi-field optimizer plan for the individual fields. That's why I am showing it to you. We have already shown this is a 3-field. It's very difficult to achieve this kind of a distribution when it is wrapping around this liver here. This is liver here. This is a chest wall. This is a chest wall. It's very difficult to achieve this conformity with a single field optimization. There is no choice. These are the targets where you use multi-field optimization. Okay. Okay. Plan mean dose. And so this is a look at in the individual. So why this was shown here? This is a 16-field IMRT dose distribution with X-rays, and this is a 3-field proton. You may be able to do a better job with X-rays by using VMAT. But at this time, when I prepared this slide a long time ago, this plan was done with IMRT, so that's what I was showing. But still then there are 16 fields. It's a large number of fields used for X-rays. No. So this is showing some dose matrices here. the heart dose, liver dose, and kidney dose. This is proton MFO plan. You can see in the 16 field IMRT plan and this plan is substantially reduced. Okay, so that is the benefit of using multi-field optimized dose for protons. And these are this is what the DVH is. If you have not seen any DVH before, this is what a DVH is. This is showing this heart. This is the percentage of prescribed dose, how much volume this kidney is getting, the 55% prescription, how much volume is getting. The physician gives you this kind of matrix that to match to do the plan as a planning objective, and you try to achieve it. So this is the target. This is the target here. Always the target will be such that you will have a full coverage. You have a full coverage and as sharp a dose possible as possible. So that way the critical organs nearby or normal tissue will be reduced. Okay, so the target coverage is always achievable by many means, by IMP X-ray machine or by proton machine. So what is the benefit of a proton therapy? That's a question that you have to remember. Now is the time to emphasize it. You can get the same target coverage using X-ray machine, X-ray dose, true beam, high energy X-ray. With the proton, what benefit you get with the protons?
Their energy will be.
No. I showed you. You had this hint here.
Minimal damage.
Yeah, the dose to the critical organs is substantially reduced. Okay, that is the benefit. Now, okay, target coverage can be achieved by by both modalities. Let's see what we have. This is case 3. This is a SFO plan. This is a SFO plan. This is a MFO plan. Okay. So what is showing? This is showing the individual field dose or something like that. Okay, you got enough example. I don't want to SFO. Left parate, 3100 LO, LPO, MFO plan. Okay. SFO plan, both fields are covering the target, and in MFO plan, this field is not covering the target. This field is covering the target, and together they are covering the target. That concept I have already shown you. I don't have to tell you again. If you take a MFO plan, look at individual fields, they will be very inhomogeneous. They will not be as homogeneous as the composite plan. Okay? So that I don't have to show you again. Energy absorber. Energy absorber is also used to bring the target dose close to the proximal side if the target is close to the proximal. Let me see what happened. Okay, I don't have to discuss this. This is just two advanced things. Let's move on. Okay, so to treating the shallow targets, you have to sometimes use an energy absorber. And the energy absorber model is done in the treatment planning system. This is nothing different. Okay, you have to choose the energy absorber depending upon what is the proximal depth of the target. If the proximal depth is target is less than the achievable the energy, the range of the energy, that's the lowest energy is available, then you use energy absorber. If, for example, you have the lowest energy 70 MeV and that Bragg peak is at 4 cm, you have a target, the proximal depth is 3 cm, then naturally you cannot cover them with that one. Unless and otherwise you do beams, high energy beams from opposite direction. They will come and deposit those, but that in that process, the beam is traveling through a lot of normal tissue. So in order to cover the target from a beam which is close to the target without going through large number of normal tissue, you add an energy absorber. So that way that 70 MeV beam range is shifted by 3-4 cm and it will cover it. Okay, that's how energy absorber is used. So if somebody asks that why they use an energy absorber, what do you say? Okay, I'll talk about this. Let's see that you understood the concept of where to use energy absorber. Who did not understand, I can explain him. If nobody raises, then I will not talk about it. I think everybody understood why you use energy absorber. Okay? All right. So we move to this. No energy absorber discussion is needed. You know where to use energy absorber. okay, for treating shallow targets. For treating shallow targets, you use a energy observer to bring the to move the Bragg peak to the proximal region. So this is a single field, single field integrated boost dose. Single field integrated boost. In this is a spine treatment. This is a spine treatment. You have a CTV which is to be covered by 45 gray, and another small region, this has to be covered by 54 gray, and this region has to be covered by 50 gray. Yellow is 45, blue is 50, red is 54. So in one treatment plan, we can achieve that goal. Okay, if you put additional spots in this region to get the dose. You put additional spots compared to this in this region, you get a 50, you get a 45. So you have now three target objectives. One is that my target CT45, it has to be the spots has to be optimized to give CTV 45 centigrade, CTV 50 centigrade, and a CTV 54 by 54 centigrade. And the optimizer will work, and from each field that dose distribution will come. Suppose you have two fields and you tell that my fields have a 50-50 weight, so then out of a 54, this field, one field will give 27, other will give 27. And this will give 22.5, this will give, other field will give 22.5. 25 here, other field will be 25. So this is how the distribution will look like. The DVH will look like in the compositive plan. The CTV 45 is covered by 45, CTV 50 is covered by 50, and GTV is covered by 60, and these are the DVH for the ORs, organs at rest. This is an example for IMPT for head and neck. Okay, this is a field 1, this is a field 2, and these are two fields. And okay, so these are there's a field 3 somewhere here. Here's the field 3. So these are the three fields. One is 280 this side, and with a couch kick of 15 degree, and then the 80 degree. There's a 80 degree field. Yeah, this is the 80 degree field. 80 degree field with a couch kick of 315 degree. And then there's a PA beam with 180 degree no couch kick. This is a head and neck target. There are multiple targets. There's a CTV 66, there's a CTV 60, and there's a CTV 54. These targets will get a differential dose. So then you do these three fields, optimize all the spots individually, and then eventually you get something like this. So this is the composite dose distribution here, and you can see that the coverage is in all different sagittal planes. Do you know this is called a transverse slice? This is called a coronal slice. This is called a sagittal slice. You know that, okay? So those people, this is taught in high school, so I don't have to discuss that. All right. So you can see the coverage is looking good in all three planes. Of course, when you evaluate the plan, you just look at a different planes also. Just scroll through. So you can look at the plan and evaluate. The DVH gives you an overall picture. It will not tell you that how the dose distribution looks on individual cuts. So when the plan is evaluated, you look at individual sections, making sure the target is covered everywhere. Okay. So these are the DVH here. CTV 60 is covered by 66, 60 is covered by 60, 54 is covered by 54, and this is a multi-field IMPT plan. So all those objectives, DVH objectives, are also used in this planning. Okay. So in this plan was not robustly optimized. If it would have a robustly optimized plan, then you have to evaluate this coverage by robust analysis. In that case, I hope I have some, I'll show you. In that case, in a different scenario, this will not have a single core. Suppose you have 12 scenarios, then you will have 12 DVS. That's the band DVS. I have some band DVS, I believe I'll show you to show that what it looks like. So these are some of the outcome data that to feel us good, because we do so much of hard work, patients pay so much of money, they go through so much of hardship coming for treatment for 30-35 days. Are you really doing some good or not? Okay, so that is the question always in our mind. Okay, so as a big center, we have a lot of data, and the physicians show us sometimes how the treatment is working well to make us feel good and work harder. Okay, that's what they want, the physicians to work harder. So they, these are the things they have found. It's a concurrent chemo with proton therapy with concurrent chemoradiation, decrease of mucositis, decrease in odonophagia, decrease in some kind of I have no idea what this is, okay, but probably no feeding tube or something, no peg tube, decrease in weight loss, decrease in xerostomia, maintain taste, decrease in dysphagia. So these are the things, good outcome from proton therapy. Okay, so it is not really it is not kind of a dramatic change in the outcome, but something the patients feel better. Okay, they have less hospitalization. So proton therapy to start with has costs a lot of money, but if you take whole patient care expenses, the proton therapy is as expensive as, it's not more expensive than other modalities. Chemotherapy costs very much, a lot of money. Okay, it's not cheap also. So yeah.
Like you were saying that it will be cost effective at the end of the
Yeah.
overall, sir, but in India, where like the patients who could be the same for proton therapy or linear accelerator, only one patient at one time. If a proton therapy costs 400 crores and one linear accelerator costs 25 crores, shouldn't we have more linear accelerators so that we can patients who could?
Yeah, agree. That is you have to look at the cost effectiveness and social context. Okay, so you don't have to, we spend a lot of money taking care of very sick patients, but we have compassion. That's why we are doing it. Okay, we don't want them to die out in pain. Okay, but there are alternative ways of taking care of them. If you have alternative ways of taking care of them, having a good quality of life, there's no point in spending money there. Okay, as I mentioned in a talk in University of Hyderabad, India or many resource-scared countries, they have to spend more money keeping people healthy rather than spending money treating sick people. First thing that you have to have a healthcare policy where the objective is to keep people healthy. That is not the objective of our health policy. Objective of our health policy is, you have more patients get sick, hospitals make a lot of money, and the government is doing more to give them money by insurance, all kinds of things. So it depends on what people want. People can also change that policy. Your health is your concern. Nobody has to take care of tell you that you live a healthy lifestyle. You follow a healthy lifestyle. Okay, that is your responsibility. If you don't follow a healthy lifestyle, you get sick, and then eventually there are people who want to make money out of a misery. Okay, the society loves to make money out of a misery. Okay, everybody is in misery. The lawyers, they want you to be in trouble. Okay, that's why they can have a case. All right. So what I mean to say is, in the context of a healthcare cost, you have to, in order to minimize the healthcare cost, you have to have a greater preventive measures so that we don't get sick. We pollute our air with driving, every family having 3 cars. We pollute our water by using fertilizers and pesticides all over our crops. We pollute our food by using additives, and then suddenly we tell that we are becoming sick. Anybody will become sick. Okay, so these are the things we have to take, and of course, the whole civilization is changing. Okay, we are measuring how we live, how we want to live. We measure our status, how many cars we have, how we wanted to drive to work. When I was growing up, not that I'm bragging about it, when I was growing up, even as a postgraduate student, I used to drive, I used to walk 6 kilometers, about 8-9 kilometers to go to my home, okay? And then in Bhubaneswar, in hot heat, I used to bike to go to different places, okay? But I was never overweight. I was never overweight, and there are not many diseases, all kinds of things. I went to USA and started eating things and become more sedentary. Then I become sick, okay? That will happen. So I don't want to preach to you, okay? I'm not, I'll stop here because you asked a question. Did I answer your question? You have to think that how to be compassionate to the patients. At the same time, make sure other societal needs are taken into account while deciding what kind of treatment you are offering. We don't have a proton machine in government hospitals. We don't have a proton machine in a charitable hospital. The proton machines, only proton machine available is in TMC, which is a free clinic. But how many patients they can treat? Okay, so they have to be very selective. The other place is Apollo. Apollo is a commercial organization. They have to make money. You don't have to go there. Okay, there are people who call me from India. Should I go to Proton Center? I said, why you have to go to Proton Center? If you have a child who has a curable disease, you take it to the Proton Center, and society should pay for it, because a child has a bright future, will live longer. We want to have a healthy child. We don't have a sick child for which we spend more money later on. Okay, so these are the things that you have to consider while you are deciding how much money you are going to spend in treating sick patients. And also, now people have money. We are a free society. What is so important in India? Give me freedom or give me death. Indian people don't want to sacrifice their freedom at all. They want to choose whatever they want to choose, okay? So they have money, I want to go, I want to get treated. It doesn't matter, okay? So, but when you are don't have money, the irony is, I'm talking about my thoughts on society or social problems. I'm not here to talk about it, but I feel like talking about it. So, where I am saying, people get very anxious. A 90-year-old parent is very sick. So what do I do? Should I bring it to America to treatment? If you have money to waste, bring it, no problem. But I cannot be that cruel, tell you not to bring. But you have to be more practical, okay? The person without, cancer at that age, the person will die from other causes. Life is transient. Life is never, nobody told that it's permanent. If doctors would have been curing the patients, they would have been immortal. They would never die, okay? So you have to look at from a spiritual angle, okay? What is our goal? Why I am living? What is the purpose of life? Am I going, if the person is being treated, tortured for 30-35 days, after that the quality of life is bad, what is the purpose of living? I want to, as long as I live a good, purposeful life, and that is the aim, okay? I'll stop preaching to you, okay? So enough. So this is a maxillary sinus treatment. This is IMPT, and this is a 6 MV intensity modulated X-ray therapy. You have to distinguish between X-ray and a proton, because both of them are IMRT, intensity modulated radiation therapy. Proton is a radiation, X-ray is a radiation. How do you distinguish? So that's why I use this term. If you are using X-ray, then I will call it IMXT. If you are using proton, I call it IMPT. So you can see the dose distribution comparison between IMXT and IMPT. In IMXT, you see that there is so much of dose outside the target. In IMPT, there is less dose around, okay? So, and this is the difference it is shown here. What else? Difference, okay, that's the difference. And this is the dose volume histogram here, okay? IMPT, IMXT target coverage is same, microscopic disease, subclinical disease coverage is same, and then you look at our benefit of protons. This is the right globe, this is the IMPT plan. You see, substantially reduced dose. Left globe, substantially reduced dose. Brainstem, substantially reduced dose. So I have sold you a proton machine. Go and find money and put a proton machine in your facility. Okay. So this is IMPT, IMXT. Okay. That's all right. It's a good. Let's move on. Now let's stop here. Let me see how many slides I have. Okay. Not yeah. I'm almost there. Let's finish it. Uncertainties. What are the uncertainties in plants? Okay. Photons, you use PTV for set of uncertainties. In protons require beam specific PTV, we have talked about it. PTV for lateral and distal proximal margins for range uncertainties. Scanning SFO, range uncertainties are not easy to take care with current TPS, excess parallel opposed beams. Smearing beam specific PTV. Okay. In scanning, range uncertainties are difficult to implement, but with a robust planning, we are able to do it. That's how they say. We can take into account the range uncertainty now with a robust planning. This is showing that in old days how we used to do, and this is the modern days robust planning. So you can take into account the range uncertainties by robust planning. Robust evaluation. Is the plan robust enough? So how do you do robust? Assuming isocenter move to 3 millimeter, range uncertainty of this, total line plants including nominal plant, device band for each volume, maximum dose or minimum dose to each volume to see the worst case scenario. Okay. So this is what happened. This is a head and neck plant, 3 fields, and this is the robust evaluation. This is the band device I wanted to show you. So what happened is this, you see this target with this uncertainty scenario, you can see that this is the lowest dose is still acceptable. Okay. The lowest dose, it may not be exactly 6600, but at least within 5% of what you expect. If you want more, you put more weightage on the robust optimization of the target. Okay. So and the CTV60 band, the target band are looking reasonable good, and this is spinal cord. This is also robustly optimized. As you can see, the change in the spinal cord dose is minimal. Okay. If you see large change happening because of the robust analysis, then that means this you don't know how much dose you are going to give. In that situation, you look at the worst case scenario. You look worst case scenario for organs at risk, making sure on the worst case scenario, the OAR is still spared. If not, try to reduce it. Okay. Thoracic cases. Motion is one of the major limitations. Interplay between organ motion with the scanning beam. More work is required. And getting repainting is better, and selected patient care treated with IMPT beams. We are the people who first started treating. We are brave people. We treated long patients with IMPT, of course, and everybody was afraid that there will be interplay effect because the scanning beam is moving, and I told you yesterday, and the long is moving, and they can get out of phase, and you will be treating something than what you planned. So, but we did, there are a lot of work done. We did first in a motion phantom. In the motion phantom, we see that how the dose distribution is being affected by certain amount of motion. And we found that if the motion is within 5 millimeter, that interplay effect is not important. And another piece of research was done that you are treating those patients not in a single fraction. They are treated for 30 to 35 fractions. So what happened is, if one day the treatment started at a different phase of breathing than what you planned, then another day it will start in another phase, another day another phase. So eventually within these 30 fractions they get average out. So interplay effect eventually converges to your plan that you wanted to deliver. So that's what something gave us some assurance that okay, we can probably treat the long cases where the motion is within 5 millimeter. If the motion is not within 5 millimeter, we don't do IMPT, or we do breath hold. Okay. If it is motion is within 5 millimeter, we treat in the average scan. Okay. These are some wisdom from this person who has done Al Smith. He was the person who was in charge of our building of the proton therapy center. He's a very wise guy. So this is his views. For equivalent optimization of plants, IMPT and IMXT provide equivalent target dose distribution. However, IMPT dose distribution have an average a factor of 2 lower integral dose than IMXT. So the integral dose determines how the patient will respond. The whole body dose is much smaller with IMPT. What else he said? Using protons, target dose can be escalated while keeping early and late effects at acceptable levels. For the same target dose, the rate of treatment complications can be reduced to IMPT plan. Okay, he was trying to sell the proton beam. Okay, he is a proton enthusiastic, so he told all those things. All right. So what are the problems with proton therapy and IMPT that we are dealing with? The problems are range uncertainties that we have already discussed, dose calculation algorithm, positioning and motion uncertainties. This leads to large distal and proximal margins. Fields aimed at organs at risk are not used. Best feature of proton beam are not most of the time used. But with LET optimization, we will be able to do it. Okay? With LET optimization, you can still point the beam towards the critical organ and just to make sure that spots are not put near it. So the initially when LET optimization was not available or we were not doing, this was one of the major problems with planning with protons. That you cannot use a beam which is pointing towards the critical organ. Of course, if the critical organ is 5 cm away, then it's okay. Then, but if it is very close, then normally you avoid to point the beam there because the LET will be high and the RB dose will be high and there will be high possibility of higher toxicity. Okay, but now with LET optimization, you don't have to cover the whole target with that beam. You cover the part of the target which is far away from the nearby OAR and the part which is closer to the OAR is covered by other beams. Okay. Dose calculation in heterogeneous medium. This is no longer a problem because we do Monte Carlo calculation now. Before it used to analytical model and then dose calculation was not very accurate. Dose planning in the presence of high G materials and artifacts in CT images, that still is a problem. Okay, when you have a CT scan and with dental implants, head and neck patients have dental implants, and then you will see their image. There is so much of artifacts, you don't know what it is. Okay, so the high entrance dose planning for moving targets we have discussed already. There are many ways now to treat the moving targets. As I told before, there is something called RGP, real-time guided proton therapy. You can put a fiducial in the moving target and do a fluoroscopic image, and when the fiducial is in the desirable location, you deliver the beam. If it moves away, then stop. So that's a beam is gated that only when the target is in the proper location you deliver it. Okay, that's possible. Or you can do breath hold treatments. There is another unsolved problem is the RB uncertainties. That we know we can calculate LET very well because LET is a physical quantity. But what is the effect of LET in the given dose is not known. So that's the question I asked that person, and that's the question we ask ourselves. In the treatment planning system, you can take the LET and calculate the RB using different empirical models. But those empirical models, the biological parameters are derived from clonogenic cell assays. Okay, so they may not be valid for the treatment. So eventually, we have to go back and do the RB calculation with different models of already treated patients, and then see what kind of outcome we are getting. Is there any correlation with a particular model is fitting the data very well, or some tweaking of the parameters are needed? That is a good area of research. Okay. Consequence of not considering range uncertainty and very low RB and plan evaluation. This is an example I am showing you what happens if you don't consider the range uncertainties. Suppose you do a plan like this. This is the brainstem. It is getting some dose here. Okay. I have no problem. No, nothing here. I forgot to give that. So if the range of the beam is actually higher than what you are showing, then the beam will move here and irradiate more of this brainstem. Okay, so the brainstem DVH will be very much affected by the range uncertainty here. Okay, so if you don't take into account, then this is the region where LET distribution, LET is very high. So if the LET is high, the RB will be high. So the effective dose to this brainstem will be very high and the toxicity can be higher, okay, than what you expect from the plant, what you see in the plant. What is the goals for future? Biologically robust dose distribution, planning with due consideration to all uncertainties, stratified by clinical trials and outcome analysis. That's what I mentioned. You take some previously treated patients, get their analyze the dose under uncertainty scenario and see what parameter has some correlation with this. Are the worst case scenarios have a good correlation? Then you use the worst case scenario for all patients. If no correlation with the worst case scenario, then we are just too afraid. We are just too scared, okay? And then RB model, which RB model is a good model, that will come from clinical outcome data, okay? That is the goal for future. Okay, thank you very much for listening. I finished the treatment planning part today. Tomorrow, we'll do some fun stuff of how to do QA, okay? And that's one of the jobs for physicists. And then if there's a time, I'll tell some my future dreams for proton therapy. What we wanted to do so that we can increase the effectiveness of proton therapy, okay? Despite all those uncertainties, I'll create a fund, a proton treatment field portfolio that will give high returns. That's what my goal is. I'll share with you. So, okay? Now it's the time for you to ask questions for 5 minutes or as long as you want. So I am done with most of the things to make you an expert in proton therapy, to become a proton therapy physicist. Previous slide. Okay? Okay. Yeah. I am closing my computer, giving you an opportunity to ask me what we discussed today or anything, okay? 2 lectures and then we'll do some exercise tomorrow, how to do a beam calibration, okay? How to do a beam calibration and we have 2 hours after my lectures, then you have plenty of time. I'll just find out whatever I get, I'll show you, okay, these 2 hours. If you think you have enough, then we can leave only. I am not in a hurry, I am leaving tomorrow, so I am in Hyderabad, I am stuck here, I am not going anywhere. So I have 2 hours, I want to make sure that you get whatever you will make you happy and think that, okay, I got something from here, okay. Go ahead and ask questions, I am here. Okay, one thing that remained, I'm going to look at the topics that we are supposed to cover. I'll look at it, anything that, any concept I have not covered, I'll cover tomorrow, okay?